Hello and good morning. My name is Ramya Kannan, and on this bright, sunny morning, I am happy to welcome you on behalf of the Hindu to Conversations. Conversations is part of the Hindu group's ongoing campaign, Tamil Nadu Smiling, that aims to bring together the people of Tamil Nadu, its retail and trade organizations and government authorities to look for solutions to bounce back from the effects of the pandemic. Conversations comprises a series of webinars in various formats spanning across industries, and the first today will focus on how the COVID-19 pandemic has put the focus on providing healthcare services to the people. As you can see, putting the patient at the heart of healthcare services. Undoubtedly, this healthcare crisis has marshaled the world's best healthcare resources to set up systems that did not exist just 7 months ago. Whether it's establishing new healthcare structures as in China or upgrading healthcare infrastructure as in India, it is possible to say that these efforts have been unparalleled. Ensuring that these new health systems that are being built are accessible, equitable, affordable, and patient-centric, and putting in place rules to ensure that these systems will continue to deliver the values uninterrupted will be our priority. Today, we have people with us who on a daily basis look at ways of delivering healthcare services with the patient at the center. We have an eminent panel today comprising of Dr. J. Radhakrishnan, Health Secretary of Tamil Nadu, Dr. Preeta Reddy, Vice Chairperson of Apollo Hospitals, and Dr. Giridhar J. Gyani, Director General of the Association of Healthcare Practitioners of India. So we will have about an hour for initial discussion, followed by about 15 to 20 minutes of questions. Please do leave your questions in the chat box. I would now like to introduce Dr. Radhakrishnan, who will be our first speaker. And really, he needs no introduction to this audience or any impact. But since I've been assigned the task, here goes. An IAS officer of the 1992 batch who qualified top of his class, Dr. Radhakrishnan has held several key positions in the government of Tamil Nadu, including this as district collector for 4 districts. He also headed Chennai Corporation as one of its youngest commissioners. In 2012, he began his stint in healthcare as the head of the state's health department as its secretary. But for a short while outside the department, he has continued to drive efforts in healthcare since then, throughout the years, be it increase in seats for medical education, efforts to achieve the SDG goals for maternal and infant mortality rates. And since June 2012, he has been the general marshalling resources of the state to battle against COVID-19 in the state. Dr. Radhakrishnan, can I invite you to start your presentation or your talk, please? Thank you.
Good morning, everybody. First of all, I would like to congratulate Hindu to have started this wonderful, Tamil Nadu Smiling campaign. This is the need of the hour, considering the kind of stress said and unsaid among a lot of people. So I'm extremely delighted to have such a wonderful audience, and also those who are seeing it in web. And apart from it, my own dear friend, Madam Preeta Reddy, and Dr. Giridhar Gyani, and of course, Ramya, yourself, you have been there from the year 2000 itself. We have been working together on health, and now you are the Chief of Bureau in Hindu, and of course, Sudarshan, who is there. I'll straight away start. Actually, I wanted to make a presentation, then I thought it will be much better to directly speak on issues. Initially, I will briefly tell, because it's a COVID era, we should know where we stand as far as Tamil Nadu is concerned. Then, of course, I'll focus on the specific topic. The good news about Tamil Nadu is that, we have entered a stage where we have started, after a prolonged pause, we started declining. And except maybe for, Chennai, Chengalpattu, Coimbatore, Salem and Erode belt, all other active cases come down, and overall at the state level also the active cases have come down below 19,000. That's the positive part of the news with which we start. And the second thing is, consistently we have been bringing down the case fatality and the weekly case fatality, all the indicators, when you look at the 7-day average of COVID cases, it is around 2,434. The 7-day case fatality is around 1.2. The absolute numbers of deaths have come down below 30 on 29 for a weekly average. These are all the positives. But COVID, when you look at, we just can't talk about what we have been doing or what has been done, courtesy the large-scale awareness, the efforts of WHO, Government of India, Government of Tamil Nadu led by our Chief Minister, or for that matter, the most important critical contribution of people's participation is this particular topic of, how to make it patient-centric. And I'll link the COVID itself, it's initially on the challenges which we had. When you look at COVID, when it started, it is not as if the world had not seen a pandemic. It had already gone through swine flu in 2000. People talk of 1918 Spanish flu. But for people like us, those who are nowadays available and we have the present lifetimes, swine flu was immediately remembering what you can remember as a challenge. 2009, it was declared as a pandemic, but maybe by middle of 2010, internationally, it was graded down to a seasonal kind of flu. That was perhaps the closest experience we had. Then we do have outbreaks. We had the challenges of dengue continuously affecting people in more than 120 odd countries. Then we also had the challenge of Ebola, which was the biggest risky thing, which started in African countries, was very effectively contained, and it could never even come to the level of epidemic proportion, except for that few countries. Then we, of course, did have Nipah also, and Zika. Zika, in fact, was identified in India. The first case was in a remote PSC in Anchatti in Krishnagiri district. These are the backgrounds in which we approach these challenges. And then Corona came. When Corona came, perhaps, from a wet market in Wuhan, people started linking it. We had already now 4 different, even though it's so common in animals, people immediately linked it to SARS in 2003 or MERS in 2013. But people never imagined the kind of pandemicity which we had seen, which we could have imagined happened immediately after that. So this is where, the necessity of being patient-centric came. When we started in Tamil Nadu, we had one institute which could diagnose, the King Institute, and we had almost 10 isolation beds identified in GH. Today, if you look at the labs, it is around 203 labs which do RT-PCR testing, and we have a capacity of 1.2 lakh. What I'm saying is patient-centric means making accessible these tests. This is one pointer. And the beds from 10, both government and private sector are today committed 1.4 lakh beds for COVID care alone, let alone the overall system. These are some of the examples which we can immediately tell to make what exactly do we mean by patient care. And then when I will directly say that, when patient-centric approach, do we mean to say that it is only a hospital infrastructure or for that matter, a testing facility? That alone is not patient care, because I have always been in my 6-7 years when I was earlier also, and I was interacting with Dr. Girdhar Gyani and all. Tamil Nadu has moved far ahead, even in though we always are viewed as a medical capital of India, state, and Chennai is viewed as a medical capital. In addition to the vibrant private sector, Tamil Nadu in the public sector also was, just like Kerala, we were far ahead of others. But there, the public demands had slowly changed from accessibility, which used to be the challenge when I joined in the service, and that used to be the issues of where is the nearest PHC, where you get the nearest doctor, to satisfaction. So that shift had already happened much before that. And when we looked at this, how to make this patient-centric, initial few months were a struggle. When you look at people were refusing to turn up, even if they turn up, there were not enough beds. So this is where I think the making available the fever camps was a very important change which we brought in, because even having a nearest urban health center or a medical facility or a government or a private facility, people were not turning up. That was our first lesson, to make it patient-centric, to make available facilities where people can test themselves. Then we found that there was a stigma associated. To make it patient-centric, we had to do a real campaign among people to make them understand this corona is not something, a stigmatized version, and unless you come forward and test yourself, you won't do, you won't, you will in fact be spreading others. So that took, and at the ground level, what we noticed was people wanted that, initially we started a fever camp. After 2 days, we will identify people to be tested. We quickly realized that that again was a mega failure, because after 2 days, by the 2 days, if he was positive, so immediately Honorable Chief Minister directed, when we asked for that, we need to make the testing immediately available adjacent to that. That happened, and adjacent to the fever camp, we started taking samples. So again, the next stage came is that when you go back, where do you take these patients? One is positive. So the thing is, to make it more, again, we were hit by the challenges that people were saying that, it takes almost 5-6 hours for us to go. Where to go, we don't know. People used to panic the moment they're told that they're positive. Then the concept of screening centers came, where with the medical college professionals and the local body officials, we set up places where people would be taken in vans or vehicles, and then they will be screened for whether they are symptomatic, asymptomatic, if asymptomatic, mild or moderate. So that next stage came, where we started triaging them and sending only the complicated cases to medical college hospitals, or for that matter, those who could afford went to private hospitals. Rest, we started sending them to COVID care center. In between, again, we found that there was a section who preferred to stay in the hospital, but they did not need intensive care. Then the concept of COVID health center, a slightly lesser level, but which has oxygen facilities, but it is not as high as a tertiary care hospital where we could do, where we could provide them facilities. So on the clinical side, these things happened, screening happened. Then the next important thing which we realized is, just by telling that, we have these many beds are not going to help us. We realized that, we need oxygen beds, treating beds. The concept of treating beds came into, and then we rapidly ramped up the oxygen capacities by, and Tamil Nadu Medical Service Corporation played a very pivotal role in helping us do that. And with all this, now what we find is, we have this capacity. We have moved out from an allegation where, contact tracing, people were not being offered test, to a place, to a situation where 24/7 somebody can walk into a SPHL, State Public Health Lab, or for that matter, a King's Institute, and get himself tested if he feels so, and if he feels that he has not been traced properly. So this is the kind of challenges which we face. But can we end up by saying that, this alone is sufficient? As Ramya in our initial address also has been pointing out, that this is a stage where somewhere down the line, the medical professionals, and I'm sure Madam Preeta and our Dr. Girdir Gani would say, we started learning. In COVID, we learned that, rapid desaturation used to happen in recovering patients when they go to restroom, providing facilities in the thing. Second is, the biggest lesson we learned is, quarantine did not mean quarantine of the individual. Quarantine, people literally, he felt quarantined from the society and the community. He was surrounded only by persons with PP. The question of allowing video interactions came in. Even the government hospitals started that video interaction, so that they don't feel so aloof. And once they are in the intensive care, they feel that, their next, something serious has happened, because they have never imagined that they are surrounded with all these people with PP. It took time for people to calm down, because many of them, out of that panic and mental stress itself, used to collapse. So these were there. And at the same time, we were hit by the tsunami of, how to tackle with pregnant women when 1% of the pregnant women were positive, to calm them down. When they were told that they have to be tested in the most anxious period of her, just before delivery, she is told she has to be tested. how anxious she used to feel. So this is the area where we found that, were challenges, and we decided to ensure that, a very important psychosocial angle had to come in. That is where we started moving with people. We found that leadership, or for that matter, being one among the team, would not happen if we sit in an AC room and start, conveying the advances of medicine to them. So we all started working with the team, being with the team, and the mental health aspect became a very critical component of this. And parallelly, we had to also, since comorbid people were very severely affected, we had to ensure that the NCD services return to normal. And of course, bringing back the elective surgeries became the last thing. As I come to the last part of thing, this is where, we are in a stage where in this pandemic, many people ask them, have we seen the last of the pandemic? Are we seeing light at the end of the tunnel? I personally feel that Europe and USA have shown us that, this is a place where this virus is extremely smart. It ensures that it finds ways and means. If we wear mask, and we quite a few people have developed some amount of seropositivity and a little bit of antibody, in spite of it, we have a chance of super spreading event. That is where I think ultimately we need to move away. COVID has taught a lesson that we need to plan for unknown. We have many hemorrhagic fevers, which we don't talk about, with very heavy mortality. We have issues where, public health has to take center stage. When we talk of patient-centric care, we need to educate patients, and we also need to tell our medical communities that we need to have that dialogue with them so that they are calmed down. Because of their constant dialogue only today, we have the sense of stigma has to an extent got away. But on the other hand, there is a general neglect on standard things like, maternal child health care, immunization, NCD. This is where I think when we talk of patient-centric, universal health coverage should not remain a utopian idea. Population-based approaches, demand-driven approaches, where people are given right kind of information, not the WhatsApp forward or a Google search kind of information. We need translational research. We need research which has to also focus on the psychosocial aspect of a patient care, where patient is calmed down. They don't panic. The caregiver is an equally important component. He is given the right kind of information. There's quite a lot of time that anxiety is there. These all things have now been constantly told to our government officials, and also we interact with private doctors also. Tamil Nadu has a challenge where people have started demanding services. I only end by saying that media needs to really support us in this particular stage, where they need to filter away unverified alarmist information, and also need to support that the right kind of peer-reviewed and authentic information goes to people. Hindu has always been in the forefront and has always supported on this IEC and information education campaign. I am sure with this excellent team of doctors, nurses, and the unseen heroes who are working, be it a conservancy worker or a multi-purpose health worker, and the resilience which people always have shown. I have seen the earlier tragedies and all. They have come back with much more vigor and vibrancy. The Tamil Nadu Smiling campaign will definitely take us all on the right track, and we all can share, use this forum to share the right, correct information, which can be used both medically and also with patients and also with caregivers. Thank you once again for this wonderful opportunity. I'll be available for interaction. Thank you.
Thank you, Dr. Radhakrishnan. And that was a wholesome overview that we had, which is what we expected from you. And I also think that you've raised a very fundamental question about what comprises healthcare. Is it only a hospital? Is it only a lab? I think these are all issues that will be discussed even in future days to come. Our second participant for the day is also someone who is no stranger to this audience. But here goes. Dr. Preeta Reddy is the vice chairperson of the Apollo Hospitals Group that has a robust presence across the healthcare system in the country. She remains at the heart of Apollo's tender, loving care philosophy that guides the hospital and essentially that centralizes the patient at in the healthcare setup. Dr. Preeta Reddy works with industry bodies and the government of India to advance policy decisions on healthcare. She was a founding member of the Quality Council of India, and under her guidance, teams from Apollo Hospital worked with the government of India in introducing NABH, or National Accreditation Board for Hospitals and Healthcare Providers accreditation. In 2013, along with Dr. Pratap Reddy, she championed the establishment of NAC Health, the Healthcare Federation of India, representing the unified and credible voice of the Indian healthcare community. She's now the president of NAC Health for the year 2020-2021. I would like to call upon Dr. Preeta Reddy to now address us.
Thank you, Ramya. As always, it's a pleasure and an honor to be with all of you. I feel particularly privileged because, Dr. Radhakrishnan and the way Tamil Nadu handles healthcare from a public sector point of view has been a role model, a case study for multiple fora when we talk about the way healthcare is being handled. And I think the state stands tall. And I must say that, what they're doing at the Omandanur Public Hospital, we go and learn from them. I have sent clinicians to go and see how are they handling things, how are they working in the COVID crisis. So to me, it's an honor to be with him. And Dr. Gyani, while you said, I was part of the quality movement, he front-ended it. He was the person who did it. I think we were all almost like students who said, let's work together, let's find ways and means. So I think the panelists, it's such an honor to be here with all of you, and thank you for the invitation. The theme says putting the patient back at the heart of the healthcare services. I'm just wondering about it because what happened with, the crisis, let's start with that. The patient just willy-nilly was always at the center of it. Now we talk, when all of us talk, we strategize, we discuss in multiple global fora. It's become almost like BC and AD, before Christ and after Christ. So now everything we do, think, plan, operationalize is like pre-COVID and post-COVID, because the way we handle healthcare, the way the game is played now is like totally changed. And I think one of the key areas where all of us are focusing on, and it really does not matter whether it's public or private at all anymore, is that we have to deal with the fear of the unknown. We have to deal with the fear which has come into families, patients, caregivers, because they need to know that, the crisis is there, but they should be able to come to a very safe environment to deal with whatever healthcare needs they have. And to do that, I think multiple communication, hand-holding, frontline workers, a lot of effort has to go into it. And I think it already has, because whether it's the public sector or private sector, and when I talk, I'm really looking at it holistically, that we have seen footfalls come in, both that, they don't hesitate to come if they have an issue with COVID, and they are not hesitating as much to come for all the other ailments, because the NCDs are there and the NCDs are growing. Emergency rooms have gotten so busy because people have actually waited before they came into hospital saying, we're frightened, will we catch COVID in the hospitals? The hospitals have to become more responsible. And that, I think, is the key about putting the patient back, is that if they did 5 steps in terms of safety and care, they have to do more than 10. They have to go much more than whatever was thought was enough. And I think that is what the key is. And to me, the secret of the care of the patient is actually caring for the patient. And every time when we talk, and in a way, we're reinforcing our old values. And we always talk to our patients. We talk to our staff, whether it's our doctors, our nurses, whoever it is, and tell them, would you treat one of your family members like this? Would you do whatever you're doing today for any one of your family members? So, you have to literally do it with a heart. And, you spoke about TLC. I think this is now TLC to the power of 10 times over, that we have to do so much more. And I think the care of patient now has become more important. So what are the steps we're looking at? We all realize now that the point of care has actually shifted a lot from a hospital environment to a home environment. So people are looking for information within their home environment. Different gadgets are available. So they know much more. So they're an informed patient. So that way it happens. Then the question arises is, do I really have to come into, a healthcare system, and can some of it be provided at home? So very structured, very organized format of it, actually the first point of care being in people's homes, whether it's, the first communication, whether it's telemedicine, which India has just seen it grow exponentially over this past phase. And that has actually come to stay. So I think if we're putting the patient back at the heart of services, we must understand that the heart and the hub is probably not, physical infrastructure anymore. It's a virtual, it's a digital space. And that's where the heart now is going to move towards. So how are we gearing ourselves to be able to function in that format? So when the point of care shifts, I think, whether it's the beginning of diagnostic work, if it's some advice through telemedicine, if it's really telling people that, be careful. So a lot of the care has shifted in that fashion. Then what we have seen is that, we did work in silos before, and I have to admit that. But now everything has become so much more collaborative, because we can virtually talk to each other, talk to the best in class researchers, clinicians, managers, anywhere in the world if we want to. And we're able to interact, we're able to research. So the care has become more collaborative. And typical example is with COVID, that, when we first started, we were completely fazed by the way the disease is, by the way the outcomes are, and what we needed to do. But quickly, protocols have happened. There have been joint protocols. We are part of some of the best-in-class research programs globally. We're testing centers for, some of the drugs, some of the interventions. So at the end of the day, the outcomes have improved. And we're not as frightened as we used to be. And we have seen that the mortality rates have really come down dramatically. And this has happened only because of collaboration. And if we can use this thought process, if we can use this kind of way of functioning for everything else in the future, I think that is really putting back the patient at the center of what we do, at the center of care. So really speaking, the I of healthcare has gone. So, now it does not exist, it should not exist. And the we of healthcare as providers, it's all about a team, it's all about the we. And it's not as if it's going to be at the center of any brick and mortar infrastructure. It's part of a huge and a large ecosystem. And that is where the shift has happened. And that is where, the patient will really come back and say, I'm going to be able to be looked after well. I'm going to get the correct and the most ethical form of medicine. I will get it at an assured price. And I think this is where the shift has been. For the patients, things have gotten better in some ways, because as I spoke about collaboration, they now are working in disease management groups. So if the tumor boards for cancer existed, let's say we did 80% were tumor boards and some were not for whatever, physical constraints, because of virtual, every patient has the option now, and it's being done, it's mandated that everyone goes through a tumor board. So I think that has been a shift to put, to be more patient focused. And the same thing, whether it's for cancer or for cardiac or in the emergency rooms, disease management groups have quickly come together, quickly fuse themselves together to collaborate so that they get holistic care. Care should never be just one part. Everyone smiles and talks about it, that a fantastic surgeon will come and say the surgery was super successful, but I don't know about the patient. I think that shift has happened, and that shift needs to happen more and more in every ecosystem, that the care has to be holistic. Why today a patient knows their rights, and they know that if I go, let's say, for a simple gallbladder surgery, I still will have the support of maybe a cardiologist and maybe somebody who will handle my diabetes. And it all will be done by a team. So a clinical team approach has come through disease management groups. And I think this has been a welcome shift to get patients back into the system. But, when I spoke about the fear of the unknown, I think all of us healthcare providers, all three of us, and of course, there's a huge role for media to play, is that the disease burden of the NCDs, while, we are frightened, we were caught unawares, and, COVID literally overtook our lives, there is this whole problem of NCDs, which is quickly catching up. So that I think we need to strategize, we need to prepare for, to try and see how can we keep people so well that they don't really need to overburden the already overburdened healthcare systems. And that would be like a challenge. Earlier it was about quality. And thanks to crusaders like Dr. Gyani, I think the quality systems are in place, and now people have to adopt it. But now we have to formulate strategies for, the disease burden of the NCDs, which can quickly overtake us. And to me, that is where everyone's mind space and focus has to go towards. And I know that it will happen because us coming together, people working together, dialogues happening together, the boundaries being removed is really a huge differentiator. And if we can keep on working together, things like COVID have come to stay. It has only taught us that you people are humans after all. You're not so superhumans. So work hard and find ways and means. And similarly, if we can do it for NCDs, if we can quickly get systems together when the vaccines come out, if we can use AI for the betterment of patients, I think we will really make the planet a healthier and a better place. Before I conclude, I just wanted to, make one small comment and, just one example. In my father's village in Tamnampalli district, we've taken about 80,000 of a population and tried to see how can we better the health indices. Just by educating them on hand washing, masking, social distancing, in one or two of the villages there's been, and with a fairly large population, there's been 0 incidents of COVID. And in the district hospital of Chittoor, where we're treating about 200-300 patients on a daily basis, the outcomes have been so good that, the mortalities have been almost, 0.5, where everywhere else is about 3% now. And I think this has been because the best in class has been adopted and implemented in these centers. So that's why I've been saying that we all have to work together, because we're actually here with the same battle and the same journey. So thank you all, and looking forward to more collaborative work sessions, working together on research and outcomes. And I'm delighted to be here with such an eminent panel and people who I respect tremendously. Thank you and namaste.
Thank you so much for that, Dr. Preeta Reddy. I think in your characteristic style, the point about collaborations and bringing down walls and boundaries, I think that was very well made. It's also something that we will have to focus on in the future. Coming to Dr. Giridhar Gyani, was the Director General of the Association of Healthcare Providers of India. I mean, I just say that because it's a designation, but anyone involved in providing healthcare services in India must know him. For years, his mantra has been quality control in healthcare, and he has for several decades been the champion of setting up quality control structures across disciplines. So the AHPI, the institution that he heads now, represents a vast majority of healthcare providers in India through a network of state-level chapters. It works closely with the key stakeholders, the government, member hospitals, the community at large to realize universal health coverage, which is a key part of our topic today. And prior to this, Dr. Gyani was Secretary General, Policy Council of India, 2003 to 2012. It is an apex national body responsible for establishing and operating national accreditation structures and promoting quality in all walks of life. So during his tenure as Secretary General of the QCI, he played a pivotal role in formulation and operation of National Accreditation Board for Hospitals and Healthcare Providers, NABH, for the first time in the country. I think Dr. Preeta has already called him a crusader, and I guess that's the right word to describe him. Dr. Gyani, please.
Thank you. Thank you so much, Hindu and Ramaya especially, for bringing me into the august company of one of the most successful health secretary of Tamil Nadu. Tamil Nadu, actually, I rate always number one state along with the Kerala, where the public health systems are, at the top of the line. And because public health are good, private sector also functions well in the state of Tamil Nadu. And Dr. Preeta Reddy, of course, I always, wish to convey my sincere regards and to her father, Dr. Pratap Reddy, whom I call as father of the privatization of the healthcare in our country. It is because of his vision that we are in such a strong position today in the world that, the healthcare of India are known, for the delivering the state of our healthcare services. So with that, let me come back to, maybe I have made 3-4 slides. Let me show if possible. It is coming here. I thought, just to strike, actually where we are. So I thought, just to give little background in a couple of minutes, that where is India? The India in terms of health effectiveness, through the Lancet study done recently, WHO done similar study, something in the 2017. Somewhere, our ranking is coming similar to what actually is shown here, 145 out of 195. Now, why their ranking is little low? Actually, it is important to understand because they rated us on the 4 A's. That is availability, accessibility, affordability, and acceptability of the healthcare services. And that is where they found that we have 1.3 beds per 1,000 population, again 3.5. Poor accessibility was the one factor because I have gone through this study in detail. They found that particularly Hyderabad, Bangalore, Chennai, Coimbatore, they have fantastic top-of-the-line hospital. But if you travel 100 kilometers from these cities, we are nowhere, that they rated us very poorly in terms of the accessibility in tier 3 towns. Number of doctors, again, we are short, naturally everybody knows about it. Only point I would like to mention here is because Tamil Nadu along with the Kerala is also proponent of the Ayush. Because if you combine the Ayush doctor, we come 1.3 doctors per 1,000. But unfortunately, we have not been able to integrate the two in whichever way manner it is possible. If we can do that, we can actually surpass the, the norm of the WHO. Nurses also, similarly, we are short. Poor compliances on regulation. This is one factor coming from the background of quality. I will always say that we do not have the good compliance. And similarly, the Human Development Index. In fact, the country should work on this index. Every state government, every central government should actually keep eye on where are we in Human Development Index in a democracy. Because this HDI is based on health, education, and per capita income. Now, coming back to this topic, because I think Dr. Radhakrishnan and Dr. Preeta Reddy, if you ask me, they have given a good big picture, in terms of where are we in COVID and where are we in the private sector, how it is doing it. Actually, Dr. Preeta Reddy knows actually that the Net Health took the lead role in formulation of the COVID task force from the industry from industry side. And I was appointed the convener along with CII and FICCI. And in fact, at that point of time, we submitted report to the government, which was accepted also. We said that in pandemic, the first line of defense will be the public sector, government hospitals, railways, defense, and and we expected that private sector will not be required to come in or pitch in. Unfortunately, it has so happened, particularly if I talk of cities like Mumbai and Delhi, that the cases are overwhelming, and we realize that in these cities and in many parts of the country, the critical care beds, critical care doctors, critical care nurses, the public sector was found to be wanting. That is the one gap actually which has been realized. And that is where the private sector's strength of having 85% of tertiary care beds overall in the country was required to come in. And I am very happy to say that, because today I am representing health private sector. I think they have come in a big way in Delhi and in Mumbai, in Ahmedabad and in Bangalore. Chennai also, but luckily I will keep saying that Chennai still has good public health system of its own. So this is where actually we are. Now, coming back to the specific topic, what Ramaya has chosen today, that the patient centricity. So I would like to show that these are the factors, 6 factors I am showing in front of you. One is that if you want patient centricity, the fundamental says, I'm going by my Quality Council of India background, that you need empowered patient, knowledgeable patient, you need healthy competition among the healthcare organization. Today, we don't talk of, customer centricity in telecommunication. We do not talk of customer, let us say, centricity in automobile, because there we have got such a good, healthy competition. But in healthcare, we have this problem. I have shown you the previous slide. We have huge shortage, in everywhere, So that is why we are not actually in a competitive mode. And then followed up by healthcare, even if you have shortage of beds or shortage of doctors, you can still compensate by bringing a good regulatory framework. Now, actually, I am going to always recommend, particularly person like Dr. Radhakrishnan and other, our friends in government, that we do not have in this country a good regulator. A health regulator I'm talking. Government regulating, I don't consider as a regulation. Like we have IRDA, like we have TRI, like we have got food sector regulator. We should have a regulator. For example, in Tamil Nadu, there are 200 plus hospitals of 100 bed and above, out of which 100 are in Chennai and Coimbatore. If there was a regulator, he wouldn't have allowed, per 1,000 suppose population, we already have so many hospitals, we should not allow. Okay, go to the other district. So that kind of regulation could have helped us in uniformly distributing the hospital and other things. Payers' intervention is also important in such a case, because payers can always define, that how the healthcare should be delivered and how the consumer should be driving the quality or the patient centricity. Role of accreditation body, I think Dr. Preeta has highlighted, is very important. And luckily, I will say the NABH, along with other foreign accreditation bodies, have been able to drive this point, and patient rights and patient responsibility is one of the important chapters. And here the government, like Tamil Nadu Chief Minister scheme, now Ayushman Bharat, CGHS also are taking help of accreditation body, which is helping in bringing the focus on the customer or patient, But of course, we have still a long way to go. And finally, I will say that we have to teach to our hospital also now that how do you bring the structure which is patient-centric. This, of course, just a couple of, just slide only to show you that healthcare in the past, if I go back 60 years back, healthcare was so safe. Everybody used to say, okay, they had total trust in the hospital, doctor, whatever he or she does, we used to be very happy. So, but today, when actually healthcare has become, absolutely, I will say, very technology oriented, very precise, and that is why the longevity also has increased, population. But still, there is always a fear today in the mind of the people when they are going to hospital, that whether we are going to a safe place or not. Today now, patient actually is Google empowered, wants best, complain about the poor communication, lack of empathy, and inordinate delay. And one point which I am worried here is that atmosphere of mistrust, that negative perception which has come in. Somewhere, it has to be, addressed by all of us, media, private sector, and government. There are certain negative points, certain minus points, but it is not like this, what actually picture we get in the nation, that unethical, overbilling, profiteering, these things which are being talked about the healthcare sector are not good in terms of that trust factor between the doctor and the patient. This has to be addressed. And this is the reason that we are seeing the increase in medico-legal cases in our country. Now, just one slide here to show you what is the meaning of patient-driven. Now, the word being used in the world is patient-driven. Patient-driven means where the patient is in the center, but actually he and his family has got role to decide in how the care is being managed about him, which actually we have still long way to go. Again, as I told you, because of the huge shortage of the resources, we are not able to do that. And this is what actually I always call that when we did a survey about 3 years back, the main problem came that today the care is being given around one medical condition. If a patient is there in ICU, there will be 6 specialists visiting him. Everybody is doing the care in his or her own way. Well, what patient wants is, why don't you cure me for my complete condition? Why can't we, there is a small board, that the way Dr. Pita was saying, the cancer board, why can't we have board which unified way looks into the complete condition and not rather a specific 1 or 2, conditions? So that is one area where patient centricity is long way to go still. So my 1 or 2 last slides are that we have to see that how do we deliver value-based care. This has to be based on the absolute transparent, objective, and patient-driven structure in the hospital. Hospital, I think I tell you, thanks to, or I think I will give my respect to all the people who are running the hospital today. It is the most complex industry, more complex than running a space, industry or automobile industry. Very complex. So you really need a good leader to drive, and who is able to create empowered team in the hospital. Then only you will be able to deliver the patient-centric services. And one of my future recommendation is, which actually is being talked about for quite some time in our country also, that gradually payers should shift to, pay for performance model, where clinical outcomes are freely monitored, available on the public domain. We must have an independent patient satisfaction index, based on which if you make the payment, patient centricity automatically will come. The bundle payment actually is also a point, which actually needs a greater debate. But this is what patient in that survey came out very strongly. They felt that why can't hospital fix a bundle payment for entire care cycle? It can be plus minus, sometimes 20% here, plus or minus 20%. But then this will remove the doubt, in the mind of the patient. When he's going to hospital, he or she doesn't know what is going to be the total billing. So bundle payment could be one of the answers, but as I said, we have to do a lot of work. So my way forward points, the last are that if you want patient centricity in the country, you have to make good the shortfall in the healthcare infrastructure. Without that, as I told you, unless you have that competition, you will always be in the supplier-driven market. So the hospital beds in tier 3 and specialists through National Medical Commission, National Board of Examination, fellowship. This has to be driven very strongly because Dr. Radhakrishnan, I am sure, must be feeling the shortage of these specialists in the community health centers particularly. Restructure the public health. I always feel that wherever public health is strong, professional and accountable, in that survey, this was one of the points highlighted that public sector today is not accountable. The medical services. Promote inverted pyramid, that is of course, patient-centric hospital, simple point. Campaign by the government and the media to empower the common man to demand quality healthcare from the hospital. That will bring the patient centricity. Payers to gradually adopt pay for performance model, I just now mentioned. And this is my point, establish health regulator. Very strong health regulator. In fact, I don't mind him saying that even some of the government hospitals, whichever states they are not running properly, can be privatized, no problem, provided you have a good regulator to regulate, the service cost conditions. After all, today you have privatized the airlines, you have privatized the telecommunication. There's nothing wrong in privatizing the healthcare in the state where it is not doing well. So, but provided you have a good health regulator. Finally, I will say, I think we have to now move from illness to wellness. We have to invest in the wellness. It will give us huge returns. And finally, is fast track the National Digital Health Mission, because this technology will bring the patient centricity very quickly. So I think this government of India has launched on 15th August. I think Tamil Nadu take the lead role in bringing the technology in the forefront of the healthcare. And this is okay anyway. So this is what I'm saying, the leadership driven. Leader is down and driving the staff and patients are on the top. This is actually briefly, I thought I would like to show you. Thank you very much.
Thank you so much, Dr. Gyani. And as expected, you have spoken about patient empowerment and standards in healthcare industries, and also an independent patient satisfaction index, and that is something that everyone needs to keep in mind. Now we can, I think, open the floor for questions. There are a few already. If we can start with the permission of the panelists, I will read out a few questions, and perhaps we can have them directed to each of the panelists wherever necessary. I think, Dr. Radhakrishnan, this one is for you. The government seems to be going ahead. This is from a viewer, Anantalakshmi. The government seems to be going ahead with the reopening of schools and colleges. In your opinion, will this lead to a rise in cases? I think there are some discussions that are going to happen with parent groups and with schools initially, but over to you, Dr. Radhakrishnan.
We've had these experiences of certain schools being opened in Andhra Pradesh and Uttarakhand and all. So it's a issue which I think health health will always be giving its feedback on the issues with regard to crowded places. Whether it is a school, a college, or for that matter anywhere 20 people gather together. I think the actual decision will be hinged more specifically on the feedback on 9th when the Parent Teachers Association and the managements and the school officials under the school education department have the consultations, and probably once the feedback comes, I'm sure we will also be giving our inputs, and at a policy level, Honorable Chief Minister will be the person who will be taking a decision based on whatever feedback comes. So till that time, my real request to everybody is that there is a general tendency. If you remember earlier, they used to talk about a Delhi-based incident. Then they used to talk about a market-based incident. I have been repeatedly emphasizing in my various interactions with the media and with the people is that we need to look at anywhere where more than 20 people gather. It can even be in your own house. During these festivals, if more than 20 people gather and if you don't have proper protection, you are likely, and you get one infected person, he can spread it. So that should be the spirit. And obviously these other challenges which one of the listeners has taken, we are taking your point into account, and we'll also be conveying it to the school education department.
Right, Dr. Preeta, I think this one is for you. There's a viewer, Premanand Ravi Kumar, who says, who compliments Apollo for doing what it does primarily. And he asks, how do you think the same is can be implemented across India, keeping lifestyle, economic concerns, and the education of people in mind?
So I think, thank you.
I think,
sorry, Ramya, go ahead.
Please go ahead, please.
So I think, this was a model which was done, and it's called Total Health, and it's in Chittoor and Andhra Pradesh. What we started doing was, we first built a hospital in Aragonda, where my father's from, and then took over that community. And these were the few things which were done. Good nutrition, teaching them to be self-reliant. The women were empowered to the extent that, they were taught skills, tailoring, so we could use those materials back in the hospitals, a little bit of backward integration. When the women started taking money home, we found that, there was a lot of tobacco chewing, there was a lot of alcoholism, there was mental depression in that community. So when they started finding a way to be busy and to earn some money, the mental quotient got better. And then we introduced yoga. And now we're seeing that almost 20-25% of them are actually doing yoga, some form of physical exercise every day. We taught them skills on organic farming. So at least, they have fresh, just basic vegetables, but they're able to grow them. So when this happened in this community, we enlarged the reach, and we said, let's take a larger population. So the district was taken. We set up a medical school and 3 nursing colleges in that area and 5 skill centers. So, people are taught, they're trained, they're skilled, so they know that they have a better future for the youth. But the district hospital was, I think, our best PPP model and exercise. And when we started, the OPDs were a little short of 1,000. They're on 5,000 now. When COVID crisis hit, a new block was built, which was completely converted, all the protocols, and we used telemedicine a lot. We all know that you can't really have super specialists going and living in places like that. And we know it's a challenge. But now technology has taught us that, they can actually give their consultation, they can give protocols. And, nowhere else have I seen that in a small village hospital, teams have gone. They have done over 250 knee replacements, bilateral knees, no infections. So what more can you say? And if this model, now the systems are there, protocol is there, it's a Harvard case study, we have global audiences looking at it to see how can we, replicate it. They want to do 5 of these in Africa. So why can't we do these in our own country? Why don't we take this up? Let it be CSR for somebody, because it is our Apollo CSR. But there are huge groups who can do this as a model for CSR. And one little point here, that the largest community of doctors who live outside India are actually Indians. And they're, Association of Physicians of Indian origin. If each one of them can, just give 5-6 hours a month, and we do video and teleconsults to whichever area they come from, remote Rajasthan, UP, Himachal, we can actually give this kind of specialist opinions to those people. So I think there are huge plans, and that's why I said that no one can walk this journey alone, and we really have to work together to implement it. I'm very excited about what the possibilities are, and I'm hoping that we can do a lot in the future.
Thank you for that. Dr. Gyani, I think there is a question on you had mentioned a non-biased healthcare regulator. I wonder if you could elaborate on that. I think
You see, now today we know that 70% of healthcare services are in the private sector. And the complaint about the private sector is basically on the cost. Now, in fact, no one among us knows what is exactly the cost of delivering a particular procedure. I think to get out of this thing, if you have a professional regulator, he will be undertaking the costing also. He will be undertaking the terms and conditions, and then it will generate the faith and trust in the minds of the people. I will give a small suggestion here to Dr. Radhakrishnan. In the government we provide free services. Now that is where people compare. Oh, they are giving free and Apollo is charging so much money. Now what Dr. Radhakrishnan can do is that all free services, let him start billing. Billing means at the rate what Ayushman Bharat or Chief Minister scheme, same rate. And then he says subsidy, same amount. Net level is zero. At least public will come to know that this is the actual cost at which government is favoring us and giving us the services. And then he or she will also be able to know that when he is going to Apollo or any other private hospital, the cost is so much and the difference he understands. So this is one of the way to remove the negative perception in the mind of the people about the private healthcare services. And again, I'm coming back, the regulator, the way you see, nobody complains about the costing of the mobile telephone tariff. Nobody complains about the tariff from any the car manufacturer, because there are regulators sitting who are seeing everything in the right perspective on the scientific basis. So I still feel that you try to prioritize those hospitals or offer those hospitals to the private sector wherever we have lack of resources. In the states, I don't want to name the states here, and then you have a good professional regulator. Let government be out of the regulation. Government has got different role to do, and let us have a professional regulator. It will improve these things drastically.
Right. That makes a lot of sense. There's a question for Dr. Radhakrishnan by Manigandan. Will special techniques be available for current medical students to be trained in to handle care in the post-COVID era?
See, already I think, if I remember, the PG students and CRRA, they have been anyway doing a lot of service, and online teaching is going on. I didn't get his question correctly, but, this COVID has also taught our health community on how to handle, even in this particular time, they have done remarkable surgeries without waiting for a COVID positive result in case of emergencies. So I'm sure that, the professors who are actually doing the teaching aspects and all are, vibrantly looking at it. One lesson which I always have been sharing with, in view of my earlier interaction during my 6.5 years of thing with health professionals, is somewhere down the line, I think Dr. Gyani and Preeta Reddy madam will agree that Guru-Shishya kind of relationship is something which we really need to develop, where there in health we need skills, and it is not just you don't have to, if you have, we shouldn't be a slave of the figures, or we recent tendency of the new graduates is to entirely be dependent on the various values and all. These values should only be supportive of actual skills by which you diagnose and treat, and that is where I feel that the various exposures they have in clinical side and during the internship side, or for that matter during the PG, should never be viewed as a burden but an opportunity to interact with seniors who have really seen. When you look at the government GH, they have treated more than 25,000 patients in COVID. So obviously they will have a 360-degree view of all complications, and that is why post-COVID clinics have been started even by us and by the private sector like Apollo in a very big way. Every day is a learning, and every case is a learning. The clot was a learning, the cytokine storm was a learning. Repurposing drugs is a very important activity, which is a learning. I'm sure in this post-COVID, once from the online we come to offline classes, as and when we come, we will incorporate, our professionals will incorporate the learnings for the way our viewer Manikandan asked.
Thank you for that. There's also a question, I think I can write two in one. There's one on how different is Tamil Nadu's approach to the pandemic, considering its successes. Can you compare it to other states? There's also another question on, comparing it with New Zealand and wondering if what New Zealand did there could be implemented in Tamil Nadu and whether it will work in TN and in the country, in India.
Which is the other country you mentioned?
New Zealand. They are comparing whether
Yes.
New Zealand.
Very good. Correct. See, first, not only this is a biological, pandemic disaster, but in disasters, one thumb rule which we had tsunami. A tsunami which affected Banda Aceh cannot be compared with what happened in Nagapattinam and should not be compared with what happened in Maldives. The entire island was drowned. And the same applies even to these kind of disasters. Definitely, the learnings are there from every. New Zealand is one of the most successful stories. But, when you look at the population, the kind of travel, we cannot compare. Now, everybody keeps asking us about the, see, first of all, we are in a phase where nobody can call it. Just like the US election, we were facing the situation till yesterday. Nobody can call it that we have seen the end of it. So we have to be very guarded. But some of the fundamentals, you see, one thing which Tamil Nadu did was the Honorable Chief Minister gave a very free hand and said that you just go by public health experts' opinion. Initially, there were different voices. Testings were, because of the lack of labs, testings were limited. But the public health experts, whether it is, National Institute of Epidemiology or WHO, Dr. Soumya Swaminathan, they aggressively campaigned. In fact, the media aggressively campaigned for aggressive testing. And that too, here I have to thank Tamil Nadu Medical Service Corporation, which ensured that we didn't deviate from RT-PCR testing, which our Honorable CM said. Some of the states in India have experimented with 60 to 70% of antigen testing, while they were able to ramp up the numbers in a very big way. But they could not follow it up with the ICMR and WHO guideline of testing the symptomatic back with RT-PCR. So this was one lesson which Tamil Nadu did. So initially in the month of May, June and all, we threw up higher numbers. We started stagnating at a level that itself was questioned, without people realizing that, within Tamil Nadu, we had areas which are not doing enough testings, like the neighboring districts of Chennai, then subsequently southern districts, and latest entrant used to be the western belt. Now that everybody else, the thumb rule of at least 10 times the average per day for the given week should be tested. Today, we test almost 25 times. That was first thing. Second was, we realized that there is no shortcut to groundwork. So fever camps, and along with fever camps, NIE campaigned that test has to be done simultaneously for any one of the symptoms. That was the thing. Next, which we realized is, we cannot hide a pumpkin. Pumpkin will be shown. If we try to hide the numbers by doing less number of contact tracing and all. So the classical thing is, fever camps help, aggressive testing help, and constant messaging, because despite all our messaging at a lower level, some overzealous officials would try to hide the numbers. So they were told, please, I remember Honorable CM telling me that please don't worry about the numbers, because if you catch the person who is going to come the next day, to that extent he won't spread. So that classical steps was there, and perhaps we ramped up the facilities very rapidly, corrected. We were very we didn't argue on genuine criticisms. We were willing to accept that, in such a large operation, there will be ups and downs. Every day would not be a good day. Every day would not be a bad day. Every decision would not be fully correct. But the chief secretary level review, college, Honorable CM level interactions, instructions at our level to the collectors, and showing them the mirror, a very honest mirror based on the feedback of public health experts, perhaps would be some of the reasons that Tamil Nadu is there at this stage. But now the biggest challenge is an element, I record it with a little bit of pain that, the response which we had in Kannagi Nagar, Didir Nagar, Tsunami Nagar, slums, and North Chennai, we don't get from upper middle class and gated communities. They're cynical about mask. while we critique that is what I saw even one of the questions they talk about masking. It is not what we say. Let us not look at it from government or something, we are sermonizing. That's the only thing the public health experts say. And till the vaccine is validated and is provided to everybody. No, it's like, okay, if the vaccine also comes, it cannot be provided to everybody at one go. Probably frontline workers will be prioritized. So till that time, we cannot ignore it. And we shouldn't think that we will be the exception if we don't wear masks. And if we do it away from the in a public view, things are. So public place should be the base. So, and standard operating procedure for every activity is permitted should be the fulcrum on which we should do. And every day is a new day, and every case till the last of the cases, we say, could be a super spreader. So we are very cautious. That is perhaps the reason. And New Zealand, perhaps, we do learn from a lot of, now we have to learn from Europe and America. The rebound of the cases was the pubs, the night clubs, and indiscriminate, non-use of masking by certain people. So everywhere we should learn from the successes. We learn from each other, even the other states, and we shouldn't compare also the states. I think all of us which use this knowledge sharing forum to adopt successful strategies. Thank you.
Thank you for that. We have a lot of very, very interesting questions. In fact, the questions are rolling in, but my team tells me that we probably have time for 3 more. There is a very interesting comment by Malini, a research student, who says, why can't you establish a dedicated disease surveillance regulatory body on a par with NIA and CDI so that GIS, open source data culture can be embraced to speed up contact tracing during the epidemic? This is also putting the patient at the center even before diagnostics. Maybe Dr. Radhakrishnan and Dr. Gyani, do you think this is feasible?
I'll just immediately intervene before Dr. Gyani says. See, actually what happens is that, what comes in the media is known to the people. There is something called as integrated disease surveillance program, which constantly monitors, every day I get what is a change in the number of inpatients, both in the government and the private sector, which roughly gives you, it's more kind of, like during HIV AIDS, we did a syndromic management kind of thing. We get to know on each diseases, both communicable and non-communicable. But what she says is right, is that, while we every day get an alert where there is a diarrhea outbreak, where there is a scrub typhus outbreak, where there is a lepto outbreak, or where there is a increase in fever, probably, it should be made accessible to the public also. This is where I think, many times we have this kind of possessiveness with data. I've always been advocating sharing of data and not feeling shy of the issues or thinking that, suddenly somebody says X number of cases. We shouldn't, and that's the kind of knee-jerk reaction the system has. So that is where I think her point is well taken. We need to also geospatiality integrated. But as far as contact tracing is concerned, I'm telling you this time, with the proper approvals of the Home Ministry, we did a very excellent contact tracing with the help of IIT and other people to know whom all people had contacted, where they're very physically accessible, what was the duration of contact, including using the call records. So there was a lot of professionalism involved. Maybe once this dies down, these all could be process documented for the other diseases. But her point is well taken that we need to do it for all the diseases and should also share it.
Thank you, Dr. Gyani.
Yeah, you see, the NCDC and ICMR have collected the data. Although, we feel that we had an opportunity to develop a much more complex template to capture data from the large number of cases which has happened in India, which would have helped in, developing the medicine and the vaccine also. I think we have perhaps missed slightly on that. But let me also tell you, the Wipro is leading a study where we are part of it now. We are collecting the data from our hospital in past 6 months, the kind of treatment protocol which were given to them and how it impacted them. So that data we are trying to collect, and hopefully in next 2 months, we will have some good study available to us.
Thank you. Dr. Preeta, maybe you'd like to say something about the HMIS that Apollo uses, with regard to data pertaining to the epidemic and treatment of COVID.
So, Ramya, I really want to say this. The first risk scan, the COVID risk scan, was done from the Apollo 24/7 team before the Arogya Setu, happened. So at that time, it almost 5 to 6 million people took the scan. What it did is that it started a trend about people actually getting into this risk scan, and it was adopted in some countries abroad. Now it's become the norm, and I think that's really a good thing. Within our systems, we did the same thing, because this is where I said there were a lot of learnings from Tamil Nadu government also, and so the fever clinics were set up within our groups. When we talk about patients coming back, I think now we need to focus on that, because whatever has been done, it can only get better. But I'm hoping that COVID is on the wane. But going forward, the recovery clinics have become very important. And I think this has to be highlighted, that unfortunately, in a lot of people, COVID has impacted their lungs, and there are heart issues which we're seeing. A lot of fatigue. I mean, fatigue to a point where you really need to see a doctor or doctor. And the fourth aspect is unprecedented amounts of, mental issues, really needing some kind of intervention. So I think our focus now must go on handling that. And that's become extremely important. The other aspect is that, the vaccine will come. It's only a question of time. The knowledge on which is the best vaccine, I think that knowledge has to be analyzed, disseminated, and I'm sure ICMR and all those bodies will tell us in which direction to take, and that has to be very clear, that they will have to tell us, because they do have the research, the data, the backup. But in implementing the vaccine, I think again, private and public sector has to come together. We have formulated strategies. My sister Shobana front ends the whole strategy and implementation of the actual delivery of the vaccine within our systems and to the patients. But imagine if everybody came together. We can be quicker, faster, safer. And then that data collection, assimilation, registries, those are the most important things to focus on. Because while we look at, the past and say we could have done this and this should be done and so on and so forth, we have to literally leapfrog into the future, because there's no time.
Very true. Thank you so much for your perspectives on that. I think a lot of our viewers want our panelists to crystal gaze and talk about when COVID will be off, when we'll have COVID 2 or the second phase or third phase. I think it's quite clear that, like Dr. Radhakrishnan said, it's impossible to call it now, just as the elections go. But in case any of you want to respond, we might have a bit of crystal ball gazing as well here.
You see, say that people keep saying that we are phase 1, phase 2. I think there is nothing like phase 1 or phase 2. The vaccine is already there in the population, in the environment. Population, I'm saying. As soon as we try to relax, again it resurfaces in a big way. And we call it the wave 2 or wave 3. It is not wave. The day you try to relax, and we know it now that this comes through the aerosol with more of 15 minutes of interaction with the infected person, and there are chances that you get infected. So this has to be communicated loud and clear to the people so that they are careful.
Thank you, Dr. Gyani. Dr. Radhakrishnan, yes.
This one constant question which people keep asking. My only suggestion to all of them is that we learned even in India we have seen Kerala wherever it has not been there when it came in a very big way. Happened in Chennai used to have 70-75% cases. Then it went to south, south started giving cases, then it went to the west. So what we learn is, and same if you look at Delhi, where almost 7,000 odd cases. One is not compromising on the basics which the public health experts say of aggressive testing. I actually say screening to healing. That should be the message. And the attitude of just getting by should be not there with anyone. And more importantly, from the public side. The second wave, all these are all basically, I would like to say that, accumulative mistakes of both the people and the administration. So the moment we relax, that's things come. But only one good thing which we learned is, the moment you have an aggressive contact tracing of, trying to get 80% of the members within 72 hours and continue the fever camps and do not relax and ensure that he is isolated, you are able to prevent it from being a super spreader like the earlier instances. That's the lesson. But definitely let us not think that, a second or a third wave. We look at it more biologically, that if we allow the virus to spread, it spreads. And it is converted into a wave. We can easily prevent the wave if all of us wear masks continuously for 3 weeks. No, that's a very simple thing, some public health experts say. But definitely in places where more than 20 people join together and strictly follow the standard operating procedures, that should be able to see us through. Finally, in the remotest event of having a symptom, instead of taking it lightly and saying that it may be an ordinary fever, just turn over to the hospitals, both government or private, get yourself tested. If you are positive, their systems are good enough if you come in early to be, prevent mortality. Thank you.
Right, thanks. And I think this sort of encapsulates the core of our discussion today, which is, science to the fore. So answer everything with a scientific approach, and I think that would work well. We have a lot more questions, but I'm afraid we can't quite take them now. Thank you very much for being a wonderful audience, and many, many thanks to our speakers for the day. And what I really like was that you brought your experience-rich perspectives to call here. And, and we are happy as part of the Hindu to have steered a small part of a very, very key aspect of public discussion, of public discourse, which is patient centrality and healthcare. Thank you very much from the bottom of my heart and on behalf of my team for having made the time and for having sat through this 1.5 hours nearly. Thank you so much, Dr. Radhakrishnan, Dr. Preeta Reddy, and Dr. Gyani.
Thank you so much.
Thank you.
All the best. Keep it up.
Thank you.
This will also pass. Thank you.
Yeah, thank you.
Good seeing you all. Thank you.
Yeah.
Thank you.